Okay, thank you. My name is Hans Isselee. I come from University of Leuven in Belgium. In Belgium you have two parts. You have the French part, the Flemish part. I'm from the Flemish part, so I call it the University of Leuven, so there's no discussion about it. Thank you to be here. It's a great honor to be on this conference. How can I move on? So, I'm a physical therapist and I have clinical experience of 25 years in patients with musculoskeletal disorders and sports injuries about the joints and tissues. I specialized in people with jaw problems, problems with the temporomandibular joint. I did my PhD about the problem of pain and the influence of sex hormones on muscle pain in the masticatory muscles. But some years ago I was attracted by one of the tennis player of my country, maybe you know her. This is Kim Kleisters. She was number one for a while, but what was the problem? She had recurrent low back pain and hip pain. And for the problem of her low back pain, her chronic low back pain, she went to a medical center in Italy and she received, what you can see here, an oral splint. And then she pretends my low back pain disappeared. So that was very controversial, and also other athletes, as some cyclists, started to use an oral splint. Also here, I had to ask my son who he was, but he's famous, sorry for that, but he's a famous football player showing to the public that he is wearing an oral splint or a mouthpiece. Okay, check. So, he uses an oral splint, and the question is can he have a better performance because of that? In a magazine of running sports, they pretend that an oral splint can influence pelvis inclination and heel rotation, or it can influence knee movement pattern. Question is this a hype, or is there clinical or scientific evidence for this? Well, then I started some research, but I have to explain oral splints. You have two kinds of splints. You have the protective mouth guard, which is used in boxing or basketball. I'm not going to talk about that. I'm going to talk about the dental splints, which is very individually adjusted and made by a professional dentist. And this has been used for therapeutic intervention. So here you can see these splints can wear at the upper arch. This is well adjusted by a dentist, and this is not new. This is well established for the treatment of patients who are complaining of bruxism, teeth clenching in dentistry, and also patients who are complaining of temporomandibular joint. And it is used to relax the mandible. It is used to relax the masticatory system. So in treatment of patients with jaw problems, this is well established. You also have oral splints for the lower arch. And a very important feature is that it covers all the teeth and that it can stabilize the dental occlusion and relax the masticatory muscles. So the features is, the aim is to relax the mandible in a stable position, to cover all the teeth, and it is important, it is a reversible intervention. So we are not talking about irreversible treatments or irreversible occlusional changes. So we don't change the teeth positions, we also place something between the teeth. So the topic of my lecture is to give an overview of a possible influence, let's say a possible influence of these oral splints on the whole body. And to look into literature, what is, if there is evidence, and we had also started some research about muscle force and very recently about dynamic posture and postural stability. So I give you a short overview. First topic, is there an influence of dental occlusion and posture? So this is a picture I saw last year in a popular magazine. Some people pretend if you change the occlusion, you can change the pelvic inclination. Well, there are review articles. They have been published in quality journals, and we can rely on their conclusion. And main conclusion is that there is not enough scientific evidence to support a cause-effect relationship between dental finding and an orthopedic disorder. So it is not advisable to perform irreversible or occlusal interventions to influence body static posture or curvatures. So you can't influence your scoliosis by using a splint. Another important review article is from Manfredini, from Daniele Manfredini. Also, he came to the conclusion that the used posturographic techniques and devices have not consistently found any association between orthopedic findings and dental occlusion. Also, Henke published an interesting review article, and he reviewed 360 relevant papers. So there is lots of research on this topic. He found articles looking for a correlation between dental findings and spinal column diseases, head posture, pelvis, obliquity, leg length inequality, and his conclusion was most of these publications failed to provide hard facts and solid evidence on static posture. The second topic is a possible correlation between dental occlusion and muscle force, and that's another story. The first study was published in 1978, so we are 3-4 decades ahead, and there is still some research about this topic, which is very intriguing. But his study was of low quality. Also in the 80s, 90s, there was lots of studies which were reviewed by Gelb. Also there, the studies have lots of methodological flaws. In the 80s, there were conflicting results, and recently, Italian colleagues, Ferrario, did some EMG studies, and he finds significant correlations between masticatory muscles, dental occlusion, and the head and neck muscles, but based on EMG studies. Okay? So we started recently, I was very interested in, is there a relationship? And we started our own study, and as a part of this lecture, I present our pilot study on a group of 21 healthy physiotherapy students, males and females, which were screened that they were very asymptomatic for oral and temporomandibular joint dysfunctions, and they were excluded from orthodontic treatments, or they were in good health and good physical condition. In the subjects who met the inclusion criteria, we placed a dental splint of 4 mm, a wax bite, and these were the strength tests we have been done. We measured the hand grip, we measured the shoulder abduction, and also the biodex for the quadriceps muscle force. Here you can see it in detail, hand grip, eccentric muscle force of the shoulder abduction, and here isometric force of the quadriceps. We had a methodologic strong design. We did these tests in 3 different mandibular positions, with the mouth open, with the mouth closed, and also without a bite, and also in a random order, and repeated the measurements after 1 week. Appropriate statistic analysis, an ANOVA or a linear mixed model approach has been done, and our results was there were no significant differences. There were only small differences, but not significant. So muscle force and limbs was not influenced by altered mandibular position. At the same time, another colleague in Belgium did the same study independently of our group, and they found that only in eccentric muscle performance they found decrease when they imbalanced the jaw. So our group, we did the force measurements with the balanced jaw, but in his study, he repeated the same study. In a balanced position, there was no difference in concentric, in eccentric, but when he imbalanced the jaw, there was only a difference in eccentric muscle performance. So that was very interesting. Here you see his results, and in the quadriceps, the hamstrings, concentric, eccentric, with no splint. With the balanced splint, there were no differences, but only when there was a resin. So there's a little piece put between the teeth, and the jaw was imbalanced, and they detected a difference in eccentric muscle performance, which is new. And this is a study from 2014. Yeah. So we did go on with that. That's muscle force. So there is possible, dependingly from the methods used, any association measurable. if we look to postural balance, and this is dynamic balance, we can measure that on the force platform, where we can measure the body sway area. You can measure the center of pressure on the foot and also the velocity of sway. This is a reproducible method. My Italian colleague Alberto Baldini, who could not be here today, but I wrote the abstract together with him, tested the intersession reliability of using a force platform, and that's okay. In that case, I will present a small case. These are pictures from Alberto Baldini, and this is a patient with a jaw problem on one side, and this is a picture from the occlusion, and you see this occlusion is not symmetrical. Yeah? You can see that on this side and on this side, but this is a topic for a dentist. I'm not a dentist, but I show the pictures to show you the clinics about their method, and they can measure with T-scan also the occlusal loads, and here you can see that the occlusion is imbalanced, 30% right and 60% on the left side. What they do, they place an oral splint to stabilize the occlusion, and they measure again the occlusion, and it is more symmetric with the T-scan. Okay, then we perform stabilometric examination on the force platform. With center of pressure, there is no significant variation, but if we look to the statokinesiogram, what a name, here you can see this is without a splint. There are lots of oscillations of the whole body, and with a splint there is less oscillation. So these instruments made it possible to measure the difference between if you change the occlusion with an oral splint, does it affect the whole body or not? But, so this is the clinical conclusion. I have to go back one. The clinical conclusion, in this patient there was no variation in the center of pressure, but there was an improvement in the oscillations in what you could see at the postural platform. Here there was an improvement in total body balance. Maybe because there was less tonus in the whole body. Okay, so with sensitive instrumentation, it is possible to evaluate, correct bite, and follow up the patients. Also in EMG studies, they found a coupling between occlusion, neck muscles, and also the body sway. This was done in 2006 by also an Italian colleague, Sforza. And there was significant relation between the foot pressure and an imbalanced occlusion. So modifications in the contraction of the masticatory muscles may therefore affect the whole body, was their conclusion. Also, they studied the influence of vision and dental occlusion on body posture in an elite group in Italian Air Force pilots. They are also elite group. They have a perfect vision and perfect physical condition. And my colleague Alberto Baldini concluded that the sway area could be influenced by the mandibular position. But as a scientist, we have to be very critical to these clinical findings. And I think, in my personal opinion, it is very tricky to draw a conclusion between what you see on the feet and to find the cause and effect relationship of a change at the occlusion. Because in the whole body there are many compensatory mechanisms. And I think that is a very difficult matter to measure exactly what is the reason if you change an occlusion, what is the body doing with that. So there are many confounding factors if we look to the correlation between occlusion and postural control, because of the many compensation mechanisms within the neuromuscular system regulating body balance. But in the clinic, some things can be seen, can be measured with sensitive instruments. I would point your attention to these compensation mechanisms because I can draw your attention to a possible relationship between mandibular position, the cervical region, and postural balance. A few slides. So this is one of the compensation mechanisms in the whole body. In the University of Leuven, my colleagues have do lots of experiments in postural control strategies, and you can see that some subjects have a control strategy, what we call an ankle strategy. So if you change or if you imbalance the control, they control their stability from the ankle, and the second person controls his stability from the hip, and another will control it to do a step forward. So there is a great inter-individual variability in postural control strategies. Here you can see the many confounding factors in postural control. You have the mobility, the spinal flexibility, muscular features, and probably also mandibular position is one of these factors. It's cognitive processing, there are visual and vestibular, and all these factors can interrelate and influence postural control. This is an interesting topic, and maybe we come to a redefinition of what is a temporomandibular joint dysfunction. There is a functional coupling between what happens in the upper cervical region, C1, C2, C3, and the mandibular movement in the jaw. This has been published in 2000 by Scandinavian colleagues who measured the movement in the high cervical region simultaneously with the jaw movement. And we also see in the clinic, when we evaluate movement, if someone opens his mouth widely, there will be an extension in the high upper cervical region. So we have to see that as a whole functional unit with biomechanical and neurophysiological relationships. And maybe here we have a possible explanation, but also a very interesting topic for further research, because it is widely accepted that the cervical region affects postural stability. So it is reasonable to believe that mandibular position can influence the cervical region, and so directly or indirectly influence postural control. So, but this is an interesting topic for further exploration in research. You can focus on biomechanical aspects or focus on neurophysiological relationships. And this is another very, this is a pilot study from an Italian colleague together with people from Qatar. I found last year, 2 years ago, and they found in a pilot study in 18 people, if they measured the isokinetic knee force with the Cybex, they found a significant influence of the tongue position. This was a pilot study, but it's a very surprising result. And if they push the tongue to the palatum in the mouth, it changes the muscle force in the limbs. But the authors concluded we had a small group, but possibly it's also a confounding factor. So I will draw the attention that this is a very intriguing topic, rather new topic, but because oral splints are used widely in elite athletes, we can ask the question, what is the factor of the psychology of these athletes? I would like to show, and this is also one of the last slides, I didn't speak about the placebo effect or the effect of the therapists, but in sport performance, I think that's also a very important, I can't say confounding factor or major factor, but I think that's an area to further explore, both biomechanically, neurophysiologically, and also psychologically. Okay. I thank also my colleagues from Leuven and Bruges, and the collaboration of the Italian colleagues is also highly appreciated for the critical reflection, and also you for your attention. Thank you.